Pulmonary resections. With the advancement of anesthetic capabilities, more and more types of pulmonary resections are developed with robotics, VATS, and other techniques. Sublobar or non-anatomic wedge resections are some of the first operations performed on the infections and neoplastic etiologies, and high-quality prospective data has demonstrated that patients undergoing wedge resection for primary lung cancer have higher rates of local recurrence. Segmentectomy differs from the wedge resection in that it follows the bronchial branches and lymphatic drainage of the anatomical segment being removed. Lobectomy has long been the standard and primary treatment for early-stage lung cancer and often as a part of multimodal approach for the locally advanced cancer. Since 1990, minimally invasive approach, first with video-assisted thoracic surgery and more recently with the robotic assistance, have become standard approaches to be associated with decreased blood loss. The right upper lobe is the most common site for development of lung cancer and has most consistent anatomy. When performing the right upper lobectomy, it is important to clearly identify the middle lobe vein and preserve it. And the middle lobe vein lies in close proximity to upper lobe vein and then typical shear drainage into the superior pulmonary vein. The left-sided resection visualization of the lower lobe vein is important prior to transection of the upper lobe vein, as a single common vein can occur. Avulsion of the apical posterior segmental branch of the left PA is common pitfall to be avoided when performing left upper lobectomy. Sleeve lobectomy is a term defined by resection of a circumferential segment of the airway in continuity with the pulmonary lobe, requiring reanastomosis of the remaining non-involved lobar bronchus and central airway. It is classically performed for proximal tumors involving the junction of the lobar airway that would otherwise require pneumonectomy. In doing so, uninvolved lung is preserved, and studies have shown that sleeve resection is feasible, safe, and minimizes parenchyma loss and avoids morbidity associated with pneumonectomy. Pneumonectomy historically has carried some of the highest rates of morbidity and mortality among the elective operation. Thus, the preoperative staging of the PFTs and lobectomy being performed whenever possible. Patient with predictive postoperative post-expiratory volume in 1 second greater than 60% of the predicted postoperative diffusion capacity of the lung and carbon monoxide of greater than 60% are generally able to tolerate pneumonectomy. A long-term oncologic efficacy of the anatomical sublobar segmentectomy resection has been investigated with a large cohort. Similarly, non-anatomic sublobar wedge resection has been proposed as a potential viable treatment for the patient with smallest T1A tumor. Thank you.